Well, thanks very much, and it's a great privilege to be able to give one of these public lectures. And the lectures I give around the UK and abroad, I always put up this picture. Now, for those of you who don't know, this is actually UCL. And I know it doesn't look like it, or it doesn't to me, UCL, but this is UCL as I envisaged it, with blue sky, happy students. It's a joyous place. Anyway, I joined UCL in about must have been about 6 or 7 years ago, and had visions of coming to lectures like this when I came out. I used to work at St George's Hospital Medical School, and I thought coming to this big place and I'd be able to take advantage of all these public lectures and broaden my education. And unfortunately, as time has gone on, and I've acquired this comet's tail of affiliations that you just heard, it's become less and less possible to do that kind of thing. But it really is a great privilege to be able to come here and at least give one of these things every now and then. So thank you for that. So what I'm going to do in this talk is start with a little bit of background information about where we stand, particularly in the UK, and actually particularly in England, where I've got the best data, on smoking, and then move on to what we know, not what we think, but what we know from the evidence we can do to encourage and help people to beat this addiction, which I think most people nowadays in the scientific community, in the clinical community, and even in the public agree is not just a lifestyle choice. It's not, people don't smoke because they want to. They largely smoke because they need to. And I'll give you some more information about that later. Well, as part of the research that I do, I and my colleagues carry out monthly national surveys of smoking prevalence in England. And you are the first members of the public to see the latest figures on this, which goes all the way up to December 2009. And what you can see is something quite interesting, which is you probably can tell that smoking prevalence is declining and has declined over the last few years. Since we've been looking at it, it's declined by about 4 percentage points, something like that. But this picture tells, or rather disguises something a little bit more complicated that's going on. I won't give you the statistics, but essentially the blue line shows what happened up to smoke-free. That was when we introduced the smoking ban. And then the red line is the first 9 months or so after smoke-free. Now, statistically, you may not be able to see this, or you may be able to eyeball it, but statistically, at that point, smoking prevalence was going down more rapidly than we've ever seen it in this country before. And I'm not saying there's a causal connection here, but let's say either coincidence or something happened, but at the official start of the recession, you can see there seems to have been a bit of a blip. And since then, it's been fairly flat, although perhaps coming down a little bit. So the situation we have at the moment is just over 1/5 of all adults aged 16 plus currently smoke cigarettes. A few people smoke pipes and cigars who don't also smoke cigarettes, but that's a very small number. And we're talking about 8.5 million smokers in England. So really quite a huge number. Why do we care? Well, as you all know, probably one of the reasons why you're here is that smoking's bad for you. But just how bad is it? I think a lot of people don't quite understand how bad it is. When I started to smoke when I was young, I had this idea, who wants to be old anyway? You know, I mean, I just want to live my life. Actually, I didn't think I'd make it to the millennium, so I'm doing quite well so far. Everything in that from now on's a bonus. But who wants to get into old age and all the illnesses and the diseases and the happy life, and then it chops off the end of it? But that's obviously not what happens. That is not what happens. It chops off the middle bit. So the bit that you lose through smoking is about 10 years worth of middle age, the bit just before you start to get sick. And if you can stop smoking, particularly if you can stop smoking at around the age of 35 or younger, you can get back almost all that life expectancy. And in fact, as it turns out, the amount of time you spend with diseases of disability, diseases of old age and disability and so on, is actually slightly less than it would have been if you'd carried on smoking. So essentially, stopping smoking adds about, if you can do it young enough, adds about 10 years of life, and healthy life at that. What this means, and these are data from Richard Doll's British doctor study, is that after the age of 35, this is a figure that I think is probably the single most important figure in smoking. After the age of 35, every year that you delay stopping, you lose 3 months of life expectancy. Okay? So it's a quarter of that time is just lost every time you delay. So while it is true that a substantial proportion of people do stop smoking, like Alan Carr did around the age of 50 or 60, even then, for them, they have already lost quite a substantial amount of life expectancy. And in fact, a relatively small proportion of smokers do succeed in stopping before that age of 35, where the clock really starts ticking. So that's really critical. So stopping smoking is urgent. It's not something that you can put off. We know about the major disorders caused by smoking. Lung cancer is obviously the one that most people know about. Not so many people know about coronary heart disease, but it's there. It's one of the biggest killers. And one of the other killers that's really probably the nastiest of them is chronic obstructive lung disease. In chronic obstructive lung disease, it's a progressive disorder. It can be diagnosed early. If you go to your GP, get them to do spirometry on you, you can tell whether your lung age is lower than it should be and whether you're on this downward slope. Once you get COPD, you can't recover. There's no recovery from COPD, so it's terribly important, and this goes to what I was saying a bit earlier about the urgency of stopping smoking. It's terribly important to catch it early and to stop smoking, because stopping smoking is the only thing that will stop that deterioration in the disease. All the medicines that we have are just symptomatic relief. There are other cancers. My father-in-law died of bladder cancer. I thought he was going to get away with it. He was actually quite a fit, healthy guy. He drank quite a bit and he smoked quite a bit. And then at the age of 69, he got bladder cancer and it killed him. His philosophy, by the way, which I wouldn't subscribe to, was that the drinking would probably counteract the smoking. But I think I don't think there's scientific evidence for that. Then, of course, we have other diseases like peripheral vascular disease, which lead to amputations. It's very rare indeed to see someone who's lost a limb through peripheral vascular disease in their 40s or 50s who isn't also a smoker. And a lot of surgeons would say it's a big waste of time doing grafts on people with these diseases, because it will come back and they will need to do it again. And then we also know about stroke. A lot of people don't know about age-related deafness, macular degeneration leading to blindness. Obviously, we know about smoking and pregnancy, infertility, miscarriage, perinatal death. And there's a paper, I haven't put it up there because I don't think it quite qualifies yet, but I think it will. There is growing evidence that smoking is linked to dementia. Not only Alzheimer's, but also vascular dementia. So some people used to think that it was protective, but it isn't. If anything, it's the opposite. So what are people doing about it out there? Well, if there's 8.5 million smokers in Britain today, a substantial proportion, these are data from these surveys that we do, a substantial proportion try to stop. Just under 40% in 2009, we now know, tried to stop smoking at least once. That's 3,400,000. What happened after that? Not many succeeded. Not many will succeed. This is the problem. A lot of people try, very few succeed. I know it sounds depressing, but that's what the figures look like. So the proportion of people who succeed long term in any one quit attempt is less than 5%. It's more like 2 or 3% of the people who try. So what we really need to do is to find ways of helping people who try to stop smoking. They're out there. They're trying, often repeatedly. Okay, so what happens when a person tries to stop smoking? This is what happens when a person tries to stop smoking. Within about a week, within a day, you've already lost a substantial proportion. Within a week, you've lost 75%. Within a month, you've lost about 90%. So the relapse rate, particularly early on in the first 4 weeks, is staggering. After that, people do carry on relapsing for all kinds of reasons. But this early period is the one that we worry about most. It's a period where there are strong urges to smoke. You get a number of other adverse symptoms, withdrawal symptoms, what we know to be nicotine withdrawal symptoms, irritability, anxiety, depression, poor concentration. You get hungry, restless. Actually, you also get mouth ulcers, you get constipated, you get a cough. Some people will tell you if you try to stop smoking, you get a cough. A lot of people know about this. They'll say, oh, this is your lungs coming back to life. They're breathing and they're bringing up all the mucus. This is such a good thing. Actually, the evidence is that that isn't the case early on. You've got a cough. That's what the problem is, because you've also got a sore throat and an earache. And we've done research showing that your immune response, the capacity to fight off upper respiratory tract infections, is impaired when you first stop smoking. So that's a bit of a kick in the teeth when you do something that you think is supposed to be healthy. So why do people relapse so much in this early stage? First of all, what this graph shows is the urges to smoke, or the cravings that people experience. And this is from a study that we carried out with about 1,000 smokers, where we followed them up over a long period of time. And you can see there that it's in those early stages that the cravings are at their worst. But you can also see from the graph that the cravings are still there for some people 6 months later, even a year later. You're not necessarily out of the woods. If you look at the other symptoms, this is just some of them, there's a very interesting pattern here. You can see that some of the withdrawal symptoms, they really cluster in the first 4 weeks. But there's one symptom that just goes on and on and on, and that's hunger. And while that symptom is going on and on and on, you are gaining weight. And you gain about 6 to 8 kilograms when you stop smoking, and mostly you don't lose it. So what's the reason for this? What's the problem? Well, we now have a lot of evidence, scientific evidence, on what the problem is and where it lies in the brain. And it looks something like this. This is my attempt to do it in 2 slides. Okay, usually this might take a couple of lectures, but bear with me. Puff on a cigarette. Nicotine is a toxin, it's a neurotoxin, is absorbed through the large surface area of the lungs. This leads to a very rapid ingestion of nicotine and a bolus of nicotine, a high concentration bolus, hitting the brain within a few seconds. And when it does that, it attaches to acetylcholine receptors in many areas of the brain, but the one we're mostly interested in is a place called the ventral tegmental area in the midbrain, you can see there. And when it attaches to those receptors, it causes activation of a particular pathway, which is sometimes known as the central reward pathway. People used to talk about pleasure centers, but it's not about pleasure, it's about reward, which is not the same thing. It activates that pathway, leading to a release of a chemical called dopamine, which many of you will have come across, in a part of the brain that's further forward called the nucleus accumbens. Now, we know that this is critical to the development not only of cigarette addiction, but also to other addictions, because if you can block that dopamine release in the nucleus accumbens, then you can only really do this in other species, because people sort of object when you cut people's brains out. But some people object when you cut other species' brains out, which is not necessarily unreasonable. But when you know from other species that when you lesion this pathway or when you block the dopamine release, then those animals will stop responding for nicotine. So what happens after that? Okay, so this dopamine release in the nucleus accumbens is a reward signal. It's a teaching signal that says, I don't know what you were doing just now, and I don't care, but do it again. That was a good thing to do. It's not about choice. It's not about you deciding you're going to smoke. It's about establishing an association between stimuli, the cues, and the impulse to smoke, what you might call a habit. It's actually teaching you a habit. Okay, so you experience these cue-driven urges to smoke, and a lot of smokers, they don't even know why they've got these urges, because it doesn't make any sense. It's not even as though cigarettes are that fantastic, but they experience these urges to smoke. In addition to that, you get, after repeated exposure, you get changes in the reward pathway, which mean that the normal levels of dopamine, which you would normally get when you experience pleasure and pain and so on, they're lower and they're not there, or they're not there. And so this turns itself or manifests itself subjectively into experience of what I've called nicotine hunger. because a lot of smokers almost report it like a hunger in the pit of the stomach. It's like an acquired drive. So the smoker's brain is saying, I need nicotine. I need nicotine. And so for a lot of smokers, particularly heavy smokers, very dependent smokers, the first thing they do when they wake up in the morning, after the nicotine levels have gone down overnight because it's been metabolized and excreted, the first thing they do is to reach for a cigarette. And that's a bad sign. Because if you're that kind of smoker who has to smoke first thing in the morning, then this is a particularly strong motive for you, this need, this acquired drive. So the two things that you end up with here are the cue-driven urges to smoke and this nicotine hunger, this background level of craving, which is gnawing away at you the whole time. And it's not about choice, although choice does come into it, because you could not eat. You could hold your breath for a lot longer than you actually do if you try. There's a lot of things we could do, but as humans, we're not equipped with that amount of strength of character or strength of will to be able to do it. So this idea that smokers lack willpower is complete nonsense. There's no difference in the amount of willpower that smokers have versus anyone else. But they're subject to this very, very challenging, extreme motivation as a result of the nicotine that they've absorbed. But cigarette addiction is not just about nicotine, it's also about psychology. So you've got the nicotine dependent side of things, which is these cue-driven urges to smoke and this nicotine hunger. But of course there are the psychological and social factors as well. The social rewards, the giving and the receiving of cigarettes, the being with other smokers. When I started smoking, I used to go out with my friends who were smoking and I didn't smoke. I just go out there and chat with them, and then eventually I'm a human being, we do what other people do. I started smoking, I don't know if any of you remember them, John Player's Special. Black packet, very cool. There's me thinking, very cool. There's other people looking at me thinking, what a prat. So anyway, it takes a few decades of maturity or approaching maturity to recognize that. Anyway, there's the social rewards. And then, of course, smokers form positive beliefs about smoking. They think smoking helps with stress. It's one of the things that smokers will tell you, oh, it helps with my stress. All the evidence is that it actually makes it worse. It doesn't make it better. What happens is when you don't smoke, you get all these withdrawal symptoms and you start to feel bad. And as Alan Carr puts it, you smoke a cigarette, relief. He says it's like taking off a tight pair of shoes, and it's pleasurable and it's relief. But all it's doing is it's relieving the withdrawal symptoms that it created in the first place. And all the evidence indicates that when people stop smoking, they actually get less stressed. So you've got the biological and pharmacological side, and you've got the psychological side. And the thing about the psychological side that's so invidious is that if it's still there years later, if you still think that smoking is going to help with stress, you get stressed, you're going to reach for a cigarette. And so that's one of the things we try and combat in the Stop Smoking services. So how do we beat it, getting onto the nub of the issue? Well, at some level, it's very easy, and at another level, it's very difficult. At some level, it's a very simple equation. At every moment after the point at which you've decided you're not going to smoke again, your resolve to smoke, not to smoke, has got to be greater than your urge or need to smoke. And the moment your urge or need to smoke goes higher than your resolve not to smoke, and there's a cigarette available, or you can go and get one, that's what you do, because that's how human motivation works. So what we need to do is to maximize resolve. And there's various tricks and tips and mental things and physical things that people can do and that we talk about in the Stop Smoking services, which can help with that. One of the things is the not a puff rule. A lot of smokers will think, oh, I can have just one, just a puff, it'll be all right. It isn't all right. It's never all right. It's almost never all right. It's a terrible idea. You've got to cut yourself off and say, not going to happen. It just isn't going to happen. Can't happen. You've got to imagine yourself like being in this lecture theatre or in a supermarket. Not going to happen. And even very heavy dependent smokers, when they're in these situations where you can't smoke, don't normally, some do, but most don't normally experience these powerful urges. When they get out of that situation, then they do, then they're dying for a cigarette. But there's something about that, the capacity of the brain to impose these rules that can say, if it's not going to happen, then you don't feel the same level of conflict. trying to develop an ex-smoker identity, the idea that that was me then. A lot of smokers, like myself, I'm not ashamed of being a smoker, otherwise I wouldn't tell you about it. And a lot of smokers are still kind of hankering after that bit of a rebel, you know, this is the kind of guy I am, I'm out there, you know, doing stuff. Not cool, obviously. But you don't want to give that up. You want to, but so what do? You say, well, I'm moving on. That was me then. I don't do that anymore. I don't do that anymore. That's our identities, as we know. It affects where you dress. It affects the people you go hang around with. It affects whether you do terrible things for terrorism or other reasons. Your identity is a very, very powerful driver of motivation, and an ex-smoker identity is potentially very important. You can set up social contracts with people, particularly, for example, your stop smoking advisor or specialist, that you're not going to smoke again. And you can go back and tell them that you haven't smoked. I've been very good. They love to say, I've been very good. I haven't smoked at all for the last week. And you can reward them. And that's very important. And then there's the personal satisfaction you get for conquering this addiction, which is difficult to conquer. And quite rightly, smokers, when they do conquer it, feel very pleased with themselves. And on the other side, you've got to minimize the urges. It's not rocket science, but it is important to do it properly and well. Avoid the cues. Don't test yourself, because you'll fail the test, probably. You know, best not to test yourself, at least early on. Avoid the cues. Reduce the physiological need. We do that largely through medication, but you can also do that through exercise, and distraction and coping techniques. Now, I'm going to go into a bit more detail on these in the last part of this talk. So what we've known for at least 20 years, and only in the last 10 years has this become part of NHS standard NHS practice, is that, first of all, behavioural support, as we call it, we don't call it counselling, we don't call it, well, a lot of things we don't call it, but it's behavioural support, practical advice from someone who's seen it all before. They've seen other smokers. They know what other smokers have been through. They know what the evidence indicates can help with smoking. So very practical advice to bolster resolve and to show how people can avoid and cope with the urges. That doubles your chances of stopping. And that's why we have NHS stop smoking services, because we know that is a very, very potentially effective tool. We also know, beyond any reasonable doubt, that adding nicotine patches or nicotine gum or this other pill that's been around for some time called bupropion or Zyban can also double your chances above that. So your chances of stopping smoking, if you use behavioural support and the medications, is about 4 times what it would be if you just tried to do it yourself. I'll show you some data on that in a minute. Okay, we've known that for a long time. That's not new. So what is new? Well, there's new data coming out on how to use nicotine replacement therapy. For example, we now know that if you don't just take the patch, but if you take one of the faster acting forms as well, like the gum or inhaler or lozenge, then you can increase your chances of stopping by about another 50 to 70%. Okay? Now, to my mind, why wouldn't you do that? Most people don't now, because they haven't cottoned onto it. But the evidence is there. Why wouldn't you do that if this is a life-saving thing to do? There's also evidence now that if you start using the patch 2 weeks before the quit date, then you can also boost your chances. So to my mind, if you're going to use NRT to stop smoking, or nicotine replacement therapy to stop smoking, the standard would be slap on a patch 2 weeks before the quit date. After the quit date, carry on using the patch and then using one of the other fast-acting forms of nicotine replacement therapy. It's not a panacea, and most people will still fail. But this will boost your chances to a level that you cannot get if you just try by yourself. The other thing that we've discovered in the last few years is, and this was serendipitous, is that if you're not ready to stop, this is something that you just feel you can't handle at the moment, but you cut down with the aid of nicotine gum or inhaler. We found that when you follow people up who've done that, they're more likely actually to have gone on to stop later on. So this is something that will be coming into the stop smoking services, I suspect, in the next year or two. The other new thing on the medication side is varenicline or Champix. Some of you will have heard about that. And if I can talk quickly enough and end soon enough, I'll give you an opportunity to ask me questions on that, or I can hang around afterwards and you can ask me more about that. But there's the evidence from randomized controlled trials that Champix is more effective than Zyban, which is about as effective as NRT, and there's also evidence that Champix or varenicline is more effective than NRT. So this is a pill that you take. It does have side effects. It makes you feel sick for a lot of people, but a lot of smokers will say, I don't mind that, because this is the first time I've ever been able to get this far with stopping smoking. So that's something to consider. There have been scare stories about Champix, as there have been about all the stop smoking medications. And if you're interested in those, you go to the MHRA website, which is the regulators that we have in this country for medicines. And the evidence is that there is not evidence for an increased risk of neuropsychiatric side effects such as suicide and so on when you look at the data properly. So these scare stories so far are without foundation. Finally, on the behavioural support side, there is less wonderful news to tell you, as it were, but there is some interesting news. First of all, we now know from systematic reviews of randomised trials that telephone support of the kind that you get face-to-face, but this time over the telephone, can help and is effective. There's emerging evidence that internet sites can be effective. The problem we have here is that we don't know what are the active ingredients of these. And we've got a grant from the Department of Health and MRC, a sort of consortium of funders to develop and evaluate a national internet-based smoking cessation program. But research is a slow business, so you'll have to wait 3 years before you can get the answer to that one. There are lots of miracle cures out there and bogus claims, hypnotherapy, acupuncture and so on. Many of them have been looked at, and unfortunately these claims are usually without foundation. So if you are interested, it's not to say that none of these things work, but the thing I would always ask of anyone who's making big claims for success is how many people started the treatment, not finished the treatment, started the treatment, and how many do you know are abstinent after at least 6 months? Because that's the only basis on which you'll be able to tell what their success rates are. Otherwise, you can get very, very inflated success rates. So psychologically, what do we know about how you can beat the cravings? These are just a few of the things. There's not a lot that we know, but these are a few of the things. Walking, just simply walking. One of the best ways, interestingly, of reducing the cravings, at least while you're doing it and for a while afterwards. Even isometric exercise, a study I did with colleagues at St George's Hospital showed that just sitting still and clenching your buttocks or forearms and things and then relaxing them can help. I'm going to go through these a bit more in a minute. There's a thing called body scan, glucose tablets and imagery. Let me just go through those finally. 5 to 10 minutes of brisk walking, without doubt, reduces your cravings for a cigarette and some withdrawal symptoms. Isometric exercise, just sitting still, because you can't go for a walk, so you're sitting still. What can you do? Tense your muscles and relax them. That will help with the cravings. Body scan is part of this mindfulness thing that's very popular at the moment. It's a mental exercise where you go round parts of your body, relaxing them, but you take the cravings and you don't try and fight them, you just look at them. And they just, and the idea is that they will disappear as you look at them. There's some evidence to support that. We've been looking at glucose tablets, just dextrosol tablets, which we know can help with the cravings. And then a study which I thought was quite interesting was about visual imagery. In this program, they used a virtual reality program on the computer, and in the experimental condition, they got people to, in the virtual reality world, crush cigarettes. And in the other condition, they had to crush something else, which wasn't cigarettes. And this is just one study, but they did find higher short-term abstinence rates. This may be something now with this sort of high-tech world we live in that could be pursued. But actually, I would think it probably doesn't need to be a computer. I think you can probably do it in your head with imagery. This is something that we can look at more. So in the stop smoking services, these are all things that, most things you can do yourself. But in the stop smoking services, what we've been looking at are what are the effective behaviour change techniques? What makes one service more effective than another if it does something differently? There's 140 odd stop smoking services around the country. Each one deals with about 60,000 smokers. So any of you, if you smoke, could go to your GP and say, I want help with stopping smoking, and if they're good, what they should do is to say, here's a telephone number, let's call this number, get you an appointment with a stop smoking specialist, and they can sort you out. Well, we've been looking at what is associated with higher success rates in these services. And the ones that I'm going to just quickly run through are measuring expired air carbon monoxide concentrations. Some of you will know about this already, but when you smoke cigarettes, you take in a lot of stuff, tar, nicotine, but you also take in a gas called carbon monoxide. And carbon monoxide is the gas that people use very often to commit suicide because it essentially asphyxiates you. It displaces oxygen off hemoglobin. It's 20 times more, has 20 times the affinity for hemoglobin than oxygen does, so you don't need a high concentration of carbon monoxide to kill you. Smokers don't get that level of carbon monoxide, but they do get quite a lot. And you can use carbon monoxide, an expired air, a sort of breath test of carbon monoxide, to see how much they've got in their bodies. So they blow into this machine, and their reading comes up, and the alarm goes off, or whatever. Oh my God, you've got high levels of carbon monoxide, and they don't like that, because that's a tangible sign of the damage that smoking is doing. And when they stop smoking, it goes down very quickly, within a few hours. So that's a tangible reward for stopping smoking. So that's something that is used a lot in the services. Other things I'm going to talk about as well. Strengthening ex-smoker identity, I mentioned. Advise on changing routines. You'll see from what I said earlier why that would be useful. Providing rewards, usually praise, can be money, but usually praise, contingent on successfully stopping, and facilitating relapse prevention and coping. I'll just go through those. This is the website, by the way, for the centre. If you want to have a look at it, it's got some interesting stuff. And if you, some of you may be stop smoking specialists and may have already tried, there's a quiz on there, an online assessment. And even if you're not, you might want to try it and see how much you know about smoking. It's open to everyone to try. The website address is up there at the top there. So just going through the carbon monoxide, I've already mentioned that, so I don't need to go through that again. Ex-smoker identity I mentioned a bit earlier. The idea is allowing you to keep your old identity, but having a very clear rule or identity that you now have, that this isn't what I do. I can't do this anymore. Even if I wanted to, I can't do this. It's not going to happen. Advice on changing routine. The purpose here is to avoid exposure to those cues. Remember what I said about cue-driven impulses. This is not a rational process. This is us as pigeons and rats and monkeys. This is us as animals. It's tapping into that part of our brain. So if you can avoid those cues, you can minimize your exposure to those cravings. And it does make a difference. Rewarding abstinence. We are very social creatures. Social rewards are among the most powerful rewards we have. And so the stop smoking specialist, if they're good, they will really lay it on thick. You know, when you come back and you say you haven't smoked for a week, they'll say, that's fantastic, well done, you must be so pleased. And I am so pleased. I am very pleased with you. It's not just you doing it on your own, I'm with you. And this is something that, you know, you've achieved. And at the end of the session, what they'll say is, I'm so looking forward to you coming back next week and saying to me that you haven't smoked for another week. This is something which is potentially very important. What we call relapse prevention and coping, these are ways, active, definite things that you do. The evidence is that if you just wait out the cravings, you'll give in. It's just not enough. You just can't do it mostly. But if you do something, it doesn't even matter too much what it is, as long as it's something very practical, then you can make a difference. What are the pitfalls? Trying again too soon after failing is a big problem. If your batteries need recharging, effectively. All the evidence is that if you try again too quickly after having failed a quit attempt, then you're more likely to fail. The idea that you can have just one cigarette, I've already mentioned that. Complacency. It's kind of like a computer game. You've got to level 5, you're over the worst of it, And how is your brain now going to trick you into smoking? Because it's still thinking about how you're going to have a cigarette. It's going to think, oh, I've cracked this. I think I'm over this. I can have a cigarette now, okay? Because I'm not addicted anymore. And there you go. We know. So you just have to watch out for that. Alcohol is a terrible one, because for all kinds of reasons, it's a cue and so on. But the other thing it does is it impairs your frontal lobe functioning, and you need your frontal lobes to stop you doing things that you're not supposed to do, and like not smoking. And having and not having a clear quit date. What we found is that people sort of ease gradually as they see it into stopping smoking are much less likely to succeed. Stress and low mood are a big problem. They're a problem not just for stopping smoking, they're a problem for anything that requires self-regulation. You need to sort of give yourself treats, and very often smoking is one way of doing it. So to beat the cigarette addiction, this is not new, this is obvious. You need a deep commitment. It's not enough just to take a half-hearted swipe at it. And you need a definite quit date. Don't sort of say, well, I don't know, but I'll sort of somewhere around that time. The option one has got to be the NHS Stop Smoking Service with varenicline or one of these new forms of NRT. If you don't want to do that because it's too much of a hassle, or you don't think, or you've tried it or it didn't work for you or whatever, then telephone support plus those medications. Otherwise, get a prescription from your doctor for one of these medications. But if you are going to go it alone, which most people who try to stop smoking are going to do, then some of the things that I was talking about you can import into your own homegrown program. But I would definitely suggest that you look at some of the internet sites, and I would also strongly suggest that you, if you do start to get into difficulty, I'll tell you what the canary is, the canary down the mine which tells you that things are not good. The canary is if you're feeling irritable. Because if you're feeling irritable, then that is one of the most common withdrawal symptoms, and it's a nicotine withdrawal symptom, and it's kind of a marker of everything else that's going to happen and going to come. And you don't have to do that. Just using nicotine gum or patches or anything like that can help. Exercising, these are all things that can help with the irritability. You don't have to go through that. If you've got a really bad headache, you wouldn't put up with it. Well, I wouldn't. Most people, from this slide, it's intended to show that most people try it by themselves, and most people fail as a result. And this is what happens. These are data from 2008, 2009 in the population, what the odds are of stopping smoking if you do it with these different methods. If you do it without help, that's our reference category, then we just set that at 1. If you get NRT bought from a shop, then we're not finding evidence that it makes much difference. If you use medication, NRT or varenicline or Zyban on prescription, then you can almost double your chance of stopping. But the thing that really makes the difference, and that I'm plugging here, and it's not just because I was one of the people who helped set it up, but I'm sure I have a conflict of interest there, but the evidence is that it makes such a big difference that why wouldn't you do that? Because it could save your life. So the take-home message is smoking is still a major problem in Britain despite the smoke-free legislation. Almost half of smokers try to stop, but the success rates are very low. They could be higher. The best option by far is the NHS Stop Smoking Services, which give practical advice plus medication. The best medication options are varenicline or this new way of using NRT. Most smokers are still trying to do it alone, and that's fine, but as long as they're aware of the options and what can be achieved if they go for further help. And the NHS Stop Smoking Services at the moment are being revamped. The centre that I'm involved in is very much involved in making sure that all the stop smoking specialists are appropriately assessed and trained and have all the skills necessary to deliver the kind of support that I was talking about. And that's it. Thank you very much.